Okay, welcome back everybody. My name is Greg Daniel. I'm a fellow and managing director here at the Brookings Institution. I'm going to be moderating this next session, which is focused on obtaining stakeholder perspectives on the future of the Sentinel system. As you've heard this morning, the transition from Mini-Sentinel to the full Sentinel system is an important landmark in the evolution of our safety surveillance system. In the last session, Rich outlined his team's plan for the future, which includes bringing in new data partners and collaborators, also highlighted some of their priorities in the areas of methods research and development. In this session, we'll have an opportunity to explore those future opportunities in greater detail and highlight some of the ways Sentinel can continue to evolve and improve over time to better meet FDA's needs, as well as needs of the broader safety surveillance community. We have a great group of panelists assembled for this session representing health systems, industry, patient advocacy groups, and research organizations who all will be able to provide their perspectives on a range of topics. Some of these topics include further opportunities and approaches to integrate electronic healthcare data and other clinical detail into the Sentinel system, growing Sentinel to take advantage of other data types and surveillance capabilities, as well as new patient populations, and also how additional opportunities are being created for other stakeholders outside of the FDA to leverage the system for expanding the way safety surveillance is conducted in the United States. I'll introduce the panelists in order. First, we'll hear from Carla Miller, who's Assistant Vice President of Pharmacy Services and Clinical Therapeutics at the Hospital Corporation of America. Joe Drozda is a cardiologist and Director of Outcomes Research at Mercy Health. Merle Weinberg is a Chief Executive Officer at the National Health Council. Sharon Terry is President and Chief Executive Officer at Genetic Alliance. Robert Reynolds is Vice President, Epidemiology and Worldwide Safety at Pfizer. And then finally, Troy McCall is the Chief Implementation Officer for the IMEDS program at the Reagan-Udall Foundation for the FDA. I'm going to give the panelists the opportunity or option to provide comments from the seated position instead of the podium, but you're all welcome to use either. So we'll kick off with Carla.
Great, thank you. Great, thank you. Hello, everyone. HCA is committed to patient safety and using data to improve patient outcomes, so we're very excited to be a new data partner with Sentinel. We're very excited, I think I've got a slide there. We're very excited about the possibilities you heard from Dr. Nguyen as well as others on what we really see in the future. I wanted to first start talking about HCA. Okay, let me start by talking about just a little bit about HCA in general. We have 165 hospitals, 115 ambulatory surgery centers. We see over 220 million patient encounters a year. We have over 212,000 babies delivered annually, and we see 1 out of every 22 emergency department encounters. We're in 20 states across the United States, and we also have hospitals in London as well. And with that, overall see about 5% of the population. So I tell you this information about HCA because I think it's important to share what the unique contribution of HCA is to Sentinel. With the depth of the clinical data, with the inpatient encounters as well as the emergency department encounters. Our near real-time clinical data warehouse allows us to use this data to move data into the common data model for the Sentinel Initiative. We've been working closely with Dr. Platt's team as well as the FDA partners to get that data moved in a way that we can easily query questions. Just talking a little bit about that data and the work that we've been doing over the last several years. Specifically in the medication space, we've been working very hard to standardize so we can get that data in a manner that we can make some decisions, look at utilization, really drill down into that. While we have work to do, I don't think we're close to being perfectly standardized. We've made a significant amount of progress in this area. HCA implemented barcode medication administration over 10 years ago and barcode transfusion administration over 5 years ago. And I tell you that for a couple of reasons. One, I think it's unique that we can actually get in and look at actual medication and transfusions administered to the patient. So when you look at data in general and how people look at medication use, many times it's secondary to an order, but you don't have all the details around the actual administration on the inpatient side. So we are able to drill down into that. In 2014, we administered over 173 million medications to patients. And with that, you can get in and look at the route, look at the NDC number, look at if it's an infusion, what was the start time, what was the stop time. So there's a number of factors that you can drill down into that you don't have in all data sets. Dr. Nguyen also mentioned the trolley initiative, and we're very excited to be a part of that work. We think it's extremely important. We've been looking at blood use utilization across our company for some time, and just looking at, once again, 2014 data, we had over 74,000 platelet transfusions and over 485,000 red blood cell transfusions. So to be able to share that information, partner, to really dig in and look at outcomes is really exciting to us. So we do applaud the FDA and all their work in leading this initiative and all the work that's went into this structure that's been created for data. This type of structure really does decomplicate the sharing process of data. As mentioned earlier, privacy is preserved. It eliminates the need for very complex data use agreements, the sensitivity of protected health information. It really does truly lead to a learning health system. So we're excited about that. So HCA is a new Sentinel data partner, and we're really excited where Sentinel is going, the future of Sentinel, and we're excited to move down the road with FDA on that.
Great, thanks, Carla. Joe?
So Sentinel has obviously done a lot of great things for FDA and for CDER and CBER. And you know, with the rule of no good deed will go unpunished, the FDA has now asked Sentinel to get into the field of medical devices, which I'm sure they will find to be a swamp. And I think facing some significant challenges as they do, as they get into this area. And I've listed a number of those challenges on this slide. The first is that up until now, at least, there have not been any device identifiers such as NDCs are on the pharmaceutical side. We now have the unique device identifier regulation out there, and as of September 24th of last year, kind of all high-risk implanted devices will have to have UDIs, and ultimately all medical devices will have unique device identifiers. So at least that is that obstacle is being removed, and I think Sentinel is waiting for UDIs to permeate the system a little bit more before venturing into these waters. Secondly, there are literally thousands of devices of varying types, all the way from Band-Aids to left ventricular assist devices, tremendous complexities, various risk-benefit ratios, etc. Some obviously minimal or no risk, some with great risk. And I think this will create some issues with respect to analyses, and especially building the system for monitoring medical devices. You can't do them all at once. You might not want to do them all, even eventually. So I think it makes some sense to start out with implanted medical devices, and I guess this will sort of illustrate the complexities of the safety analyses and even the research analyses of medical devices. One example here is the operator patient and device paradigm. So when you give a medication, enalapril is enalapril, and you do have to kind of look at the patient population you're administering it in. But in the medical device world, you also have to factor in the operator, the implanter. and the impact the implanter skill has on the performance of the device. And you also, again, have to consider the patient population in which the device is being implanted. So coronary stents, for instance, can go in patients who are in the middle of having a myocardial infarction. They can go into patients who have severe 3-vessel disease and heart failure, or they can go in fairly low-risk patients with 1 or 2 vessel disease, and that will impact the performance of the device. So there are a lot of methodologic issues that we're going to need to be addressed by Sentinelists in the area of medical devices. Another point that I've Sentinel will be challenged with is that claims are actually a poor data source when it comes to medical devices, since there's really no link between the patient and the specific device. All we know is from a claim that the patient has had a coronary stent implanted or a hip implanted or an ICD, but we don't know exactly which one. And so it makes it difficult to use claims as in evaluating patients who had implanted devices, although claims are obviously an excellent source of outcome data once you do know which device a patient has implanted. And finally, when you are looking at medical devices, you really need to capture the device attributes as much as you do the device itself. So, for instance, metal on metal hips. It's a hip replacement, but it's metal on metal. I think it's a key attribute that obviously had a major impact on device performance. So these are just a few of the challenges I see as Sentinel moves into the medical device space. But I wouldn't want to leave you with just challenges. I think there is definitely a path forward. The first, obviously, is the wider implementation of unique device identifiers in the healthcare ecosystem. Incorporation into EHRs, into device registries, and into claims data will greatly facilitate the ability to track devices through the system and assess safety and effectiveness. Secondly, I think the Sentinel really needs to look at linking to device registries where they exist as a data source. A lot of key clinical information is available in orthopedic registries and cardiovascular registries, etc. The next point is something that's maybe not as intuitive as it should be, and that is the need to link to supply chain and EHR-related data as a primary data source, as opposed to claims. This has a whole host of issues, and that's how do we capture it? How do we capture those data? It's going to happen in an automated fashion. Right now, we're not doing that particularly well. But without it, we're going to have difficulty tracking medical devices. So we're going to have to grow the number, I think, of clinical data partners in order to do this and do it well. Simply because if you're looking at implanted devices, there are a relatively small number of implants relative to, say, medications that occur in any one health system, and it would be very difficult to do a really good job of post-market surveillance without having a lot more data partners to generate the volume of data you're going to need. Ultimately, in order to make this happen, these new approaches are going to have to be piloted. We're not going to be able to do thought experiments on this. We're going to have to go out and work with health systems to capture the data we need and be able to track those data over time. And the final point here is that work in this area is already underway. FDA through CDRH has initiated this effort called MD-EpiNet, the Medical Device Epidemiology Network. And there's been a lot of work done by MD-EpiNet, including establishment of a National Post-Market Medical Device Surveillance System Planning Board under the direction of Brookings and Mark McClellan and Greg Daniel here, that will be coming out with a report at the end of the month. There's also a registries task force thinking about how registries might be used in medical device surveillance. Sentinel will have to be very closely aligned with all of these efforts, and I think conversations are already underway.
Great, thanks, Joe. Next would be Merle Weinberg.
So first, I wanted to just share a couple of things about the National Health Council for those of you that are not familiar with the council. We're unique in that we are a nonprofit umbrella and have about 100 national organizations and companies in our membership. What makes us unique is that in addition to our core constituency, which is about 50 patient advocacy organizations from large like American Cancer Society, Heart, etc., we have disability, rare diseases, organizations that represent people with disabilities. But we also have pharmaceutical companies, like Pfizer. We have healthcare providers. We have health insurers. We ultimately have all the stakeholders as dues-paying respected members of the National Health Council. And so through our infrastructure, we're able to bring all of those perspectives and data to the table, which I believe makes our positions on behalf of patients much more thoughtful and sophisticated and robust. So that's from whence this information came. One of the things that I've done other times when I've been here is really talk about patient engagement. And we now have a very large initiative, a major initiative for the National Health Council focused solely on patient engagement. And what we found is, and you heard this morning, is kind of like everyone's trying to do it, everyone believes it's important, but we don't know how. And so we have no shared framework for how to do it. We have not had a common definition. And so we've been working with all of these different entities and are bringing them together to create a framework, create the definition and some methods. And so what I'd like to share, because I think it's applicable to, for sure, the Sentinel Initiative, FDA, companies where we're working with them on patient-focused drug development, and on, we need to find ways to do this in a very organized way. So the first slide I have just lays out in a very simple way some things to think about as we try to identify very important, promising methods of patient engagement. So we need to think about when, for any particular initiative or project, when we want to engage patients, determine what the objectives or purpose are for that engagement. Who do we want to engage? We think very differently about a patient versus a more healthy consumer versus someone from a patient advocacy organization that represents the condition from the beginning and throughout its life cycle. And then only after some of that is done do we move on to some of the specific methods. Hope you can read this. So this is just the beginning, but it does allow one to think, okay, as we look at these big boxes, what are some of the things that exist now or we should consider? And I'm not going to go through these, but thinking about when to engage, depending on, again, the initiative, developing the research questions. You'll hear that from all of these entities, and certainly from PCORI. We need to engage the patient perspective up front. What questions should be asked, what data should be gathered, and what are the outcomes that they're looking for. And you can read those others. The determining the purpose, again, we have to think very clearly about why are we engaging patients in this particular enterprise. And it could be to better understand the disease and the impact of the disease on that population, or as we are doing more and more on subpopulations, so that we really are digging down to a more granular level of the sort of human experience with that condition. We think it's incredibly important to have ways to engage patients so that they're able to share their aspirations, where they are in their life, what they would like to accomplish, and what their goals are, because it's critical to the type of research that they would want to have conducted and the type of care that they'll be looking for. And again, at the bottom is back to what I said about who to engage. We have very clear definitions for these three categories and think that they each bring something to the table. It's not always the same, and you may want to engage one or the other or both of, or two or three of these groups at the same time, depending on where you are in your initiative. Only when that is done, really, do you move to what are the different methods. And that was one of the reasons I asked Rich the question. We need to think about this in a much more, as I said, sophisticated way. So here are some of the ways we know patients are engaged now. Focus groups, surveys, open forums, workshops, advisory panels, and I was glad to hear that the patient representatives for Sentinel are on the planning board, and they're not one person anymore, and they're not stuck off over to the side to be called upon periodically to find out what they think about something. That's not what we're talking about. We're talking about integrated, and from day one, throughout the research and development process and all the way through FDA approval and post-marketing surveillance. I have some other information up there, but I'm also going to run out of time. My last slide is just to, this is sort of the way we think about our mental framework and everything that we should all be doing, and that is patient, obviously at the center, focused on the patient, taking into account whether we're talking about quality, safety, healthcare delivery reform, the patient perspective, and bringing all of that together. And we talk about the patient trifecta so that we can think about this together in an organized, sophisticated way to get the best outcomes from any type of patient engagement that we undertake. Thank you.
Great, thanks, Merle. Sharon will be next.
Thanks very much. So I come here primarily and firstly as a mom. I have 2 kids with a genetic disease, is why I got into any of this. I have a master's in religious studies, and I'm a former college chaplain, never having taken a single biology course. I have worked in this field since they were diagnosed 20 years ago in a whole host of ways, and Merle, I love what you said. We came to the National Health Council years and years ago for lots of this kind of support because we were being invited to the table. But that meant the table was already set, people had already designed the meal, people had already decided who else would come and where we would sit. And I think now we're finally moving into a phase where we, the people, will be part of deciding all of those things in a real true way. And I'm delighted to work with Rich and with Sentinel in the patient engagement place. I'm with Genetic Alliance for the last several years, and I'm posting this question here about patient engagement. We're tired of being engaged. We actually would like to get married. And in many, many ways, I think that's what we are about, and I'm delighted to be part of that. So in working with Genetic Alliance, which is a network of about 10,000 organizations from all over the health field, to empower individuals, families, and consumers to be involved in these entities, I have kind of pondered these questions both from a practical aspect as well as a policy one. And I also should say I'm on the executive committee of PCORNet because I'm one of the funded PPRNs, which is PCORNet's way of saying patient-powered research networks, and I'm coordinating those with Rich in the coordinating center there. We know that people are where we start and end, and I think as I listen today, and often as I listen to these conversations, we're trying to use a lot of surrogates for getting to what happened to somebody, whether it's a medical record, whether it's some kind of surveillance system, but they're all sort of surrogates. And we also know, and on this slide I'm depicting that lots of individuals now are walking around with devices. So back to what Joe was talking about, I think the individuals themselves could be part of the delivery of information to systems like Sentinel, given that they want to and that they understand the reason why they would be doing that, because we now have lots and lots of ways of, either from our Fitbits or from all these devices that are now part of our lives. I think that brings up a lot of issues. As Rich said in the beginning, data is not your friend, and any data is not a panacea, so we're not going to find the solutions here either. I see these as a real complement to the systems that we're building. I'm showing you here a dashboard from a system that Genetic Alliance has been building for about the last 8 years that essentially takes things like you just saw and takes medical records and takes self-reported information and puts all the kind of control preferences for data sharing, data privacy, and data use in the hands of the individuals. And what you're looking at is a moderately complicated dashboard that essentially looks at information data in 3 different ways: discovering it, exporting and using it, or contacting me and deciding in various categories whether to allow, to deny, or, unusual for lots of registries, ask me. And through foreign keys and lots of technology that has been well advanced over these years, we're now able to allow people to live in any of these categories whenever they want, believing that people have very different ideas about privacy. They have very different sensibilities around the context they live in. A mother of a child might protect that person's privacy until she's 2 or 3 and has autistic tendencies, and then may want that child in a research program or in a surveillance program. So this simply gets to where we let people make those decisions one at a time, but all together as well. It's also been said that those people might have a hard time making these decisions, and we give the people guides that come from their community. So right here you're looking at people with pulmonary fibrosis and what the guides in that community say and how they feel about privacy and data sharing, et cetera. Just an example of actually something that is becoming fairly well known, and that is that individuals really want this to be pretty frictionless. They don't want to have to go to a special effort. We see in the U.S., 4% of individuals are involved in clinical trials, and that's because most people don't know how to get in one or why they would want to be in one. And so we're really trying to move this into the pathway of the individual. We know individuals will adopt technologies really fast if they're useful to them and if they understand the connections. And that ends my slides. The one last thing I'll say is that there are a number of these growing. So PCORnet, part of PCORI, in fact has 18 of these PPRN. There could be even more in the second phase. We're essentially connecting them around the U.S. and the globe because many, many conditions know no boundaries, as we well know. And essentially getting the individual back into the equation, back into a central role, and connecting it with all this other information, I think will be the way that will really enliven systems like Sentinel in the future.
Great, thank you, Sharon. So next we'll hear from Robert Reynolds.
Okay, thank you. I don't need that since my slide is already up. So in thinking about the presentations earlier today, I think it's clear that there has been a major shift in the way that we conduct safety assessment. We've gone from reliance on spontaneous reports to the increased use of real-world data. And we're using that real-world data for signal evaluation, signal refinement, and also, as we heard from Sieber, hypothesis-free signal detection increasingly. Now, this to me is a result of technical developments, but it's also a result of the availability of electronic medical records data as well as transactional claims data in the US, but also in Europe, Japan, China, Korea, and now other countries in the world. So this is a global phenomenon. It's not just limited to the US. I think also another important thing to remember is that electronic healthcare databases have been used for years by industry and others for drug safety. So what's really important in thinking about what's unique today is the size of the distributed databases, the availability of common data models that support rapid cycle analysis, multiple standardized definitions of endpoints and confounders, and also better methods for addressing bias in epidemiologic studies. Now, Mini-Sentinel has contributed greatly in this area and is really transforming how we assess the benefit risks of medicines. It has, and I think Sentinel will, enhance patient safety. And by doing so, it increases public trust in medicines as well as the regulatory process. Given that, Pfizer supports the maturation of Sentinel to an enduring, robust, active surveillance tool that is able to detect, refine, and evaluate signals. Now, as this tool's use increases, I think it's important to remember two aspects. One is that Sentinel provides a single line of evidence on potential harms, and two, that harms must be considered in the context of benefits. So in any rigorous assessment of benefit risk, we need to examine the totality of evidence, looking for convergence across sources, whether these be preclinical, clinical, or post-approval. So I was asked by the organizers to provide some general reactions to Professor Platt's presentation. And clearly, as I've just said, Mini-Sentinel is a well-organized system. It's already provided value to the FDA and public health. Now, with expansion to more data, or information as Rich would say, and data types and testing of new uses, it's clear that it has the potential to increase its value to society. I have 4 points, though, that I would like to cover. First is the proposed data expansion. Obviously, adding patients aided by government insurance, the elderly, veterans, and men and women on active duty, as well as inpatient data, will make Sentinel more representative of the American population, and it creates the ability to evaluate a broader range of therapies in different healthcare settings. Now, linkages to the National Death Index, birth and cancer registries will improve outcome ascertainment. And I also think that there's really advantage in enhancing Sentinel through linkage to disease or therapy-based clinical registries. So for some therapies, like biologics or therapies intended for targeted patient populations, safety surveillance in electronic healthcare data alone is not optimal. And this is because key data, such as measures of disease severity, tumor grading, or smoking status, are unavailable. So in these circumstances, I think linkage to existing patient registries that have rich clinical data, such as ongoing RA registries in the US or the EU, may enhance Sentinel's capabilities. Now, with the addition of this new data to Sentinel, it's important to fully extract the value from these data systems. And these data systems have unstructured data, such as physicians' notes. So we need to have some emphasis on new methods to use this information. In research that I've been involved in recently, we've used natural language processing as a way of looking at unstructured medical text to improve the timeliness and accuracy of identifying acute liver injury events. So we need more research on these types of methods in order to really take advantage of the new data that will be coming into Sentinel. And I'll also say that as we do increase the use of methods, we heard a lot about prompt and tree scan statistic. I think it's important to communicate the strengths and limitations of these approaches, and also to explore visualization tools to better communicate to non-scientists what it is that we're actually doing when we run these statistics, for example. Second, to fully realize Sentinel's potential, I think we need to think not just about safety, but risk management. So it's worth exploring the use and performance of the network to evaluate risk minimization actions. I saw on one of the slides that it looks like that may have been done, at least in one or two examples. These actions might include safety alerts, label changes, education materials, Dear Healthcare Provider letters. Now, I recognize that the data are not able to capture the full dimension of physician and patient reactions to such measures. However, I think it's possible to look for evidence that these actions inform physician behavior. So this could include looking for when required labs are ordered, or whether or not approved labels contraindications are actually followed. Presumably, it's also possible to monitor the effects of these actions over time so that we could learn which are most successful and find out, do they vary by physician specialty, indicated patient population, or maybe even by healthcare system. So my third point is that companies operate in a global environment. And this means that there are multiple credible data sources and lines of evidence. So important lessons have been learned from methodological research in the US, particularly from OMOP and now Odyssey. But equally important is the potential for fostering collaboration with initiatives outside of the US. So these include Europe's IMI Protect and the EU ADR data networks, the CNODES network in Canada, and the recently formed Asian data network called ASPEN. So I think that collaboration here may yield methodological insights, and it also provides information from different healthcare systems and populations, which could inform our understanding of patient therapies in US populations. And again, Professor Platt mentioned that the outreach to various networks have already begun, so this just seems as if it could be a natural extension of some of that work that's started. Lastly, a mechanism by which queries from other stakeholders could be answered, assuming there is appropriate governance and the questions are of public health importance, is needed. The ability of industry to access large distributed data networks and the tools that we see in Sentinel, for example, will provide an opportunity to conduct safety queries more efficiently and rapidly than is currently possible. Now, it's clear that broader access to the Sentinel has to be thoughtful, and it cannot interfere with FDA's Sentinel operations. Sentinel-like capabilities are important to safety and risk management functions in companies. And that's because it's a tool to enable industry to apply rigorous scientific approaches to proactively characterize the risks of medicines and vaccines, whether that's refining signals from spontaneous reporting systems or fulfilling FDA, EMA, or other regulatory agency commitments. Now, this is one of the reasons why Pfizer is a supporter of the Innovation in Medical Evidence Development and Surveillance, or IMEDS program, within the Reagan-Udall Foundation. And you're going to hear more about that program from Troy in a minute. But one of the goals of IMEDS is to engage multiple stakeholders. So Pfizer is working in collaboration with IMEDS and the data partners that make up Sentinel to address this goal. And we're doing that by being sponsor of the first pilot to test run safety and risk management queries that are directed by a stakeholder other than the FDA. Now, there is clearly much work to do in this pilot because it needs to create robust governance with policies and procedures that guide how stakeholders other than the FDA would access the capabilities of the Sentinel network. In an ideal future state, regulated industry, though, will have the option of submitting queries into the system in partnership with IMEDS and the data partners to fulfill regulatory obligations as well as to undertake additional activities that are part of a therapy's risk management program, and ultimately with a goal to ensure patients' safe and appropriate use of medicines. Thanks.
Great, thanks, Robert. Troy, you're next.
Great, thanks, Greg. And Robert, thanks for the segue. I'm here today, as Robert already alluded to talk to you about the Innovation in Medical Evidence Development and Surveillance Program, or IMEDS, which is offered by the Reagan-Udall Foundation for the FDA. Reagan-Udall is a 501c3 organization which was established by Congress as part of FDAA in 2007, the same legislation, of course, that created Sentinel, to help advance the science needs of the FDA. IMEDS is a public-private partnership within the foundation that's designed to build upon the significant success that you've all heard about today, made on research methodology by FDA's Sentinel Initiative, including its Mini-Sentinel pilot, as well as projects that were completed under the Legacy Observational Medical Outcomes Partnership, or OMOP. A core goal of IMEDS is to support FDA's Sentinel system. IMEDS creates and fosters an inclusive environment that enhances continued engagement, participation, and roles of multiple stakeholders as Sentinel evolves, and is committed to ensuring the transparency of both the processes as well as the findings coming out of the program. IMEDS serves to advance the science and tools necessary to support post-market evidence generation on regulated products, including safety surveillance and evaluations, and to facilitate the utilization of a robust secondary electronic healthcare data platform for generating better safety evidence on regulated products in the post-market environment. To accomplish these objectives, the IMED program covers three key areas which are depicted on the slide. First of all is IMED's methods, which supports the development of a methods research agenda and coordinations of methods research in support of using electronic health data for safety surveillance conducted by FDA, as well as the broader community of researchers. Some of you in the room may be aware that in 2014, we launched our very first IMEDS methods research agenda. By any measure, we had a very successful year in accomplishing the goals that we set forth in that agenda. Coming forward very soon, you'll see a public announcement with regard to the launch of our 2015 research agenda, which, as we did in 2014, we certainly are going to be soliciting the public's help. Those efforts have been largely driven by Alec Walker and Susan Gruber, and certainly want to recognize them for their efforts, but certainly there were literally dozens upon dozens of people who were involved in providing feedback, ranging from industry to academia, of course, to the agency and other stakeholder groups. IMED's education is the second component, and here we offer educational opportunities in areas related to medical product safety surveillance, in addition to methods research and application for scientific professionals. The third key area of IMEDS is IMEDS evaluation, in which we apply the methods and education lessons learned for medical product assessments to facilitate leveraging Sentinel tools and capabilities toward creating that national resource that Janet referenced earlier in evidence generation. Now, I have more to say about IMEDS evaluation in just a few moments, but first of all, I want to say a few words about the organizational structure within IMEDS. And this is something that Robert alluded to in terms of ensuring that we have proper governance associated with how the program will be run and managed on a daily basis. First of all, the IMEDS program team is responsible for managing all aspects of the program and is comprised of Reagan-Udall employees, contractors, as well as seconded staff from other organizations. So that's the operations side of it. We also have a number of governing bodies that are responsible for providing strategic guidance to the IMEDS program team on the mission and vision, the scientific guidance, and oversight of the various partnerships in which RUF participates. These governing bodies, which of course include the Reagan-Udall Board of Directors, the IMED Steering Committee, and the IMED Scientific Advisory Committee, are comprised of stakeholders from a wide cross-section, including regulated industry, data partners, providers, academia, patient and consumer advocates, and FDA and non-voting members, to ensure that IMEDS remains an effective, unbiased, and transparent public-private partnership. I'd now like to focus on the third key element that I've referenced before, and that's IMEDS evaluation. As you've heard earlier today, FDA's vision for Sentinel absolutely includes leveraging the tools and the system capabilities for broader public health and safety issues by stakeholders, not just those associated with the FDA. One such stakeholder group is regulated industry, which of course comprises drug, biologic, and medical device manufacturers. In order for those companies to respond in a responsible manner, rapidly to safety issues, and to meet their regulatory obligations, high quality and validated data sources must be available and accessible. Thus, IMEDS evaluation was created, at least in part, to allow FDA's vision for Sentinel to be ultimately realized. Access to the data and the tools comprising Sentinel through IMEDS evaluation will address the potential limitations of passive spontaneous reporting systems and studies performed in a single database. In addition, these distributed networks may offer an important advantage to studies conducted across a small number of databases through their use of common data models. If successful, regulated industry would access the system through partnership with IMEDS and our data partners to fulfill regulatory obligations and other activities that are part of a medical products risk management system, such as a post-approval safety studies, active surveillance programs, or evaluations of the effectiveness of REMS program elements. In order to accomplish these goals, IMEDS evaluation intends to build collaboration among Sentinel data partners, investigators, and non-FDA entities such as regulated industry to apply lessons learned from IMEDS methods and the tools and capabilities used by Sentinel to conduct safety assessments of marketed medical products. As Robert just mentioned, a proof of concept exercise has been launched earlier this year in the form of the IMEDS evaluation pilot project, which of course is being sponsored by Pfizer, but also involves close collaboration between other members of regulated industry, FDA, the Sentinel data partners, Harvard Pilgrim, and other stakeholders. The primary goal of the pilot project is to lay out what the policies and procedures would be once the program is ultimately rolled out in full production mode. In the future, IMEDS evaluation will provide an opportunity for non-public or private organizations to sponsor projects that utilize Sentinel's tools and data infrastructure through the data partners to evaluate important medical product safety concerns. By using the same data and the same tools, which includes, of course, the same methods, and by completing the same types of safety assessments as the Sentinel system used by the FDA, IMED's evaluation helps improve the consistency of safety surveillance activities in the United States. In conclusion, IMEDS is an important program which is sponsored by the Reagan-Udall Foundation and supported by a comprehensive list of stakeholders, including FDA, regulated industry, academia, advocates, and others, to promote safety surveillance and provide an additional layer of protection to ensure that marketed medical products are indeed safe for patient use. Thank you.
Great, thanks, Troy. And I'd like to thank all of the panelists on this session. They were just fantastic presentations that really can inform the future of the Sentinel system. We've reserved some time for question and answer with the audience, but before we get there, I do have some questions for the panelists. As you've heard this morning, the Sentinel system strategy over the next couple of years will bring on new types of data, new patient populations, with the Hospital Corporation of America becoming a new data partner, PCORnet clinical data systems becoming involved with the Sentinel system, also new populations like CMS, VA, DOD. It seems the methods approach is focused on statistical techniques and new efficient study designs and methods for doing safety surveillance. But one thing, Robert, that you touched on is that as you bring in these clinical data, many of which are unstructured, not standardized like we're used to seeing with the claims data, as you know, and I think Joe and Carla can comment, and you see a lot of variability in clinical data from even hospital to hospital and even within hospitals from department to department. And Robert, you brought up an important point about the methods should also focus on understanding what the data mean and understanding, you know, if we know what they mean, can they then be valid and reliable estimates or data points that would be useful for the Sentinel system. So my question to the panelists and maybe Joe and Carla, first off is, what advice do you have as Sentinel progresses with the methods agenda? Obviously, all of the clinical data won't be able to just automatically be dropped into the common data model. Some defined series of approaches from methods understanding need to happen. But I'd like to get your thoughts, since you're so close to the data yourselves, on what a logical approach or any insights that you might give to those in the room on how Sentinel progresses on that front.
Great question. First of all, talking about the variability of data, I think that as we drill down into clinical questions with our clinical data warehouse, what we found is if you've been in one HCA hospital, you've been in one HCA hospital. So there is a significant amount of variability within the data, but that doesn't prevent us from moving forward with data analysis, and I think that's an important point that I want to make. I don't think we're ever going to get to a perfection, or anytime soon, get to perfection of data standardization. We need to continue to work in the direction of moving towards standards. That in the meantime, there's still ways of working around those standards and getting very meaningful information out of this data. For the future, I really think that if we start looking at 5-10 years down the road, what are the questions that we're going to want to be having very quick answers to, and starting to work on standardization, and especially in those areas. That's one thing we did in the pharmacy space. We knew what we were evaluating at that time, but we knew where we wanted to move in the evaluation, and we slowly started working towards standardization. And as I said, we still have a lot of work to go, but we've made a significant amount of improvement in what that standardization looks like in the medication space. I think as partners in all data elements, we can start having those focus groups talking about 5-10 years out, what do we need to be answering, and how can we start getting our data to the point where it's much easier to navigate.
So I'll second that motion about perfection, and I think we have to be looking at these sorts of data in ways that we say, well, how good is good enough? And I think if we don't do anything until the data are perfect, we'll never do anything. So I agree with that approach, and I think the cooperative efforts to standardize data for these purposes can give us a lot in terms of the experience others have had. And I'm particularly looking at OMOP as an example. That they've been working at this for some time now, and I think about the 4th or 5th version of the Common Data Model, and working with people in the field through support from HRQ and others. They've learned how to get to the appropriate data elements, the ones you really need, and how to be able to standardize those across multiple providers. We're currently looking at working with them now at SODC, I guess, in terms of bringing data that is important from the standpoint of medical device surveillance. So, so if we don't get too hung up on perfection and we work on those data elements that are really necessary for purpose, I think we can move this ball forward.
Great, thanks. And Joe, just to pick on you a little bit further on the medical device side, you mentioned that there's a tremendous opportunity to get devices into the electronic health data to support device surveillance. One pathway is getting UDIs into claims data. Another complementary pathway is getting UDIs into the electronic medical records. Both of those pathways are complicated and challenging and likely to take a good number of years before we get very consistent and adequate measures of devices in those data systems. But we need to do a good job of device surveillance now. The devices are out there. We need to make sure that we can do and potentially leverage Sentinel to the extent that we can to provide some meaningful surveillance around devices. So you mentioned potentially linking with registries, but can you talk a little bit more on some feasible path forward to start doing at least, some, implantable, maybe starting with implantable devices, but how can Sentinel really leverage what the UDIs that are coming out in the more near term?
So this gets to how good is good enough again, and to the moving this effort forward in a way that's realistic and practical. Starting small and building big, but always with the end point in mind of what this system will look like when it's done, and we're able to proactively monitor all medical devices that pose some level of risk as well as benefit to patients. So that's been our philosophy in moving forward in this work at Mercy and with our data, with our partners, Geisinger, Mayo, Intermountain, and Kaiser. So there's already a lot of good work out there. I think if you look at what Kaiser's done in the area of orthopedic devices in conjunction with Cornell and the International Consortium of Orthopedic Registries, you'll see some really great information coming out of that just with what we currently have in terms of data. I think we can work together at this point on specific devices that do indeed have UDI attached to them to really put together a methodology for going forward with implanted medical devices, but at the same time answer important questions about some significant devices like coronary stents, ICDs, the orthopedic implants, etc. So we actually have the pieces in place right now to develop this system for those devices, and I think we need to keep pushing this forward at this point and not wait until we can do it all for all devices.
Great, thanks. I'd like to turn a little bit to patient engagement. So Sharon, to sort of pick up on your, our patients are actually ready to get married, not so much stop being engaged. But my question to you and Merle is, who walks them down the aisle? We have, if you look at Sentinel right now, or Sentinel as of yesterday, a lot of the data partners are health plans, and health plans routinely interface with their members. New data partners that are coming in are hospital systems and large health systems, and they routinely interface with their patients. And so, FDA can play some role in engagement and bringing patients closer into the system. But, I'm wondering, what can health plans do? What can hospital systems do? What can patient advocacy groups do? In the short term, what are the questions or at least the concerns that patients have today, and how can not just FDA but other groups help with that?
So I'll start, and I'm going to turn this over to Merle because I think she has some great ideas about this. So one of the first things I would start with is, why does someone have to walk them down the aisle? There's this massively paternalistic perspective in medicine and in health that's just astounding to me as a person who continues to come to it kind of from the outside and certainly from the inside. At the same time, I get why we ask questions like that, because systems like these are not naturally built to have this severely imperfect data, although I would argue that we can go to the electronic health record and to other claims data and see some severely deficient data as well. So I think on the one hand, I want to also ask this question from the point of view of, let's be participants, let's be active in this, the way consumers have in other fields. And it might seem trivial, for example, to use the example that when you want music to, you name a song and I can download it right at this minute, and we couldn't do that 5 years ago. That's trivial, but we can come to that same kind of sensibility in medicine. And then I think there are lots of ways that we can start with people, with advocacy groups, with health plans, et cetera, that are going to be required to have their participants be more active. And I think I'm going to, at this point, turn it over to Merle, because I think National Health Council has a lot of ideas about this.
So I would agree with your first comment. So we are they, we all have, at one point in our lives, probably chronic conditions, and we're all really smart. I would just say that our patient advocacy organizations that I mentioned are quite sophisticated. They are able to, through their PPRN with PCORI, a number of them have grants, bring together the registries they already have. They've been asking these kind of questions and setting up systems for years about how to link their patient and the health record data. They have health record data, they have life experience data, and they have research registries. And they are able to bring all of that together and are at the point now where they're able to be the intermediary quite often with companies and with other researchers that really need that information, and they need that holistic information. So we have a number of groups that are very down the road in working with different groups. I would say that the National Health Council is specifically involved, as I mentioned, with the patient-focused drug development efforts. There have been a number of companies, including Pfizer, come together, and their chief scientific and medical officers have established this very integrated partnership with patient organizations. I believe, are you on that too? Yeah. So in that effort, together, we're defining how should patients be involved in very meaningful ways in the entire drug development process. So I guess what I would say is there are very ongoing, effective ways for patients and patient organizations to partner in all of the things we've talked about, and going to an umbrella organization or an organization like the Genetic Alliance is sort of one-stop shopping. We know how to find people. We have programs that can be modified to train people for the core competencies needed. And that's one thing I didn't mention. We need, for every effort where we should be doing it together, to be clear about the objectives and what are the core competencies needed for anyone serving on that board or in that effort, and then train people to do that if they do not already have the expertise and skills that are necessary. So there are approaches and there are training, and again, these people are, and their organizations, quite sophisticated, and you heard it even from the Genetic Alliance. So I think going to people and sitting down and having those initial conversations, there's really a rich amount of information and processes and systems already underway.
I would just add to that that we've learned to speak in the language we need to speak to be part of this conversation. And so, for example, I sit on the ONC's HIT Standards Committee for the last whatever many years it's existed. We know we need data standards. We know we're working hard on common ontologies. We're figuring out how do we connect to the common data model so that our data can be accessed as well. So I'm 100% in line with Merle's idea that each of us needs to be competent, certainly, to be in the conversation, but we've developed systems to do that. And now I think the FDA and others are listening through patient-focused drug development, et cetera, and hearing some new things when we use crowdsourced platforms, when we bring people who generally can't come to White Oak or post to the docket and bring their perspective into the conversation as well.
Great, thanks. I want to turn to Troy and Robert here and talk a little bit about the IMEDS program, and I think more specifically the IMEDS evaluation pilot project. It's a two-part question, so you can decide who answers what. But one of the questions is for manufacturers being able to use this system. Can you talk, maybe Robert can start, can you talk a little bit more about when a manufacturer might be interested in actually running a query within the system? And then it's a sort of a two-part. So the part related to that is then presumably the FDA might be interested in that query, or at least be interested to know that it's that the system's being used for that. What are the preliminary results? Is there a pathway, or is there some plan for FDA to also be part of that process?
Okay, I'll part of the question might best be answered by FDA, but I will take a stab at answering it. For the first part, I think that actually what we heard earlier in the earlier sessions about how we think about risk management and pre and post approval safety assessment, that would really mirror what we would expect manufacturers to look to use IMEDS program. In that same way. So what I mean by that is that if there were a new therapy in the pre-approval phase being reviewed by the FDA and there were identified and potential risks, I would imagine that it could be agreed that those risks would be monitored in the IMEDS program system. It would probably be either a regulatory commitment or a regulatory requirement. I think it's clear that in those cases, based on my past experience, we would expect the FDA to be very involved, to provide input early on in the design and the definitions of endpoints, confounders, the main objectives of the protocol, and frequently so would external academic experts would be involved in that. So I think with the IMEDS program, we have all of the right partners there to reproduce that. In the post-approval phase, it is perhaps different because we, of course, have spontaneous reporting systems. We have ongoing clinical trials. There are many places by which a signal could emerge. And I think if a signal emerged that of concern, and what I mean by concern is that it was significant public health concern, that the FDA or EMA, other regulatory agencies, felt that it was a situation where we needed to use a robust tool like the IMEDS program or Sentinel-like program, then that would be a place where we would potentially engage in signal refinement activities or signal evaluation. And I would expect that the signal itself, as well as discussions with the FDA, would guide the approach that would be taken. And then finally, I think we're very far from this, and I think this may be where the FDA would have to choose how involved it wanted to be. But if we were to use IMEDS for hypothesis-free signal detection, so the idea that we'd be looking for events that are unsuspected in the post-approval phase, I think that might be something that IMEDS ran on its own, or by having sort of maybe predefined events that we think are possible to occur in relationship to a drug. Or it might be an area where the FDA wants to be more involved, and I think that would really be a question for them to answer.
Okay, great. Well, thanks again to all the panelists. I would like to open it up to the the folks in the room, any questions regarding the presentations or the topics that came up? Yes.
My name is Kai. Thanks. And as a pharmacoepidemiologist in industry, I'm always struggling regarding the data quality, completeness, and consistency. And I think Sentinel has tremendously improved the speed and the capability of pharmacoepidemiology database study. But I think it is important to standardize and the data collection, and so that we don't need to struggle with what Richard has an example, that for the blood cell count, there are so many, almost 100 different units. So I think I'm wondering if Sentinel, for the next step, can provide some effort to improve the standardization of data collection and the recording at the first step. Thanks.
Yeah, that's a good point. I know the folks at Sentinel do, or at least within the operations center, do spend a tremendous amount of time trying to standardize, what we call dirty data. The lab results data generally are difficult to standardize. Other types of clinical data that might be coming in. So there's a tremendous amount of effort that goes into at least trying to standardize how those data are stored into the common data model. But I think your question is a little bit further upstream in actually collecting the data. I don't know if I have a great answer, but maybe I'll turn to either Joe or Carla down at the end that might have a little bit more experience in at least how some of these data are recorded. And I'm not sure if you have the answer either, but maybe any context to provide.
I'm assuming that we're talking here about capturing data in the electronic health record, and obviously that continues to be a challenge. It was discussed actually earlier today. I'm fully on board with standardizing as much as possible. And I will talk about different efforts that are underway to do that, and then in terms of structured data capture right at the point of care. I'm a member of the Board of Trustees at the American College of Cardiology. I'll state that right up front. But the American College of Cardiology has actually come out with several statements now on structured data capture during procedures. The most recent one was last year on cardiac catheterization data. The whole idea is that data would be captured during a procedure in a way that it was now discrete and available for use subsequently. And I think we're going to see more and more efforts along those lines. We're currently advocating for the use of a structured report, office visit report, to be used by cardiologists when they're following patients in the office, that will capture specific data elements that will be required for performance measures and other purposes. So I think we're going to see more efforts at structured data capture going forward. ONC is moving that effort forward in a lot of different ways. So I am all for natural language processing that was mentioned earlier, but I think we have to minimize the amount that we have to go to that for capturing these key clinical data elements.
Okay, thanks. Diana, you have a question?
Yes, I'm Diana Zuckerman from the National Center for Health Research. Obviously, Sentinel's goal was an early warning system for safety issues, but with more and more drugs being approved on the basis of surrogate endpoints, and the whole issue of safety and efficacy going together, and the fact that a drug might have more side effects but might be more effective, is there room for looking at both of those things at the same time in the Sentinel system or in IMEDS? Or
yeah, that's a good question. I don't think yet one we don't have any answer for. But I think, as you heard, as the data systems evolve and the ability to collect more clinical data, mirror it to other administrative data that's in there, will grow the opportunities to look at different outcomes. I think Sentinel itself will stay, focused on safety, as it should, but the question is how can that be mirrored with some of the benefit data that might be out there. I might punt that to the next panel,
Okay, all right.
because that's sort of the focus of that panel. But it's a good point, and I think it does bring in what Robert, also what you brought up in more of the structured benefit risk framework, that you can't look at just a safety outcome in isolation, that the clinical context and the patient population obviously needs to be included. There's a very, very good point to bring up. Any additional comments on that point from the panel?
But by the way, I would point out that patient-reported information and capturing that will be key to looking at effectiveness of drugs and devices.
Okay, thank you.
Great, thanks. Yeah, go ahead.
I am Holly from GlaxoSmithKline. So I appreciate the good progress of Mini-Sentinel development recent year and wonderful modular program and prompt tool. However, when we implemented modular program and a prompt system in-house, we faced some issue we would like to raise for your consideration. The first thing, we have a UK database, CPID, and CPID is one of gold standard database, EMR database. However, modular program developed very specific for US database, particularly, for example, like medical diagnosis, ICD-9, ICD-10, whatever, but not fit for Reed or Osmith in a UK database. Medication, NDC or class, whatever, also not fit for Multilex or product code in CPID. The second thing, come back into we implemented in multiple database, US database, and for example, some database, they don't have date of birth. We don't know this you first of like January of the year or July or whatever. And also, when we found this crude incident rate for income of interest, we don't know whether it is consistent or not, because in the report you don't only show this point estimate, but not like 95% confidence interval or the age and standardized, whatever. So, thank you.
Okay, great. Thanks for the comments. Sure, I think Robert?
Yeah, I just want to make a point. I think that's those are important observations about some of the limitations of common data models. And I think Joe made the point earlier about OMOP, and that's, to me, one of the advantages of the IMEDS program and its lab of bringing together some of the lessons learned from Mini-Sentinel and OMOP, because they do have different common data models, and people have tried to put electronic medical record data into the OMOP common data model, and I think that's the lessons learned there are really going to inform the next steps for Sentinel.
Thanks. Trinka?
Yeah, hi. Trinka Koster, Department of Army, Pharmacovigilance Center. You guys done a great job now with signal detection, FDA communicating new risks for new products, and what we're seeing on the other end, the health of our patients and our prescribers, is you start out with a new drug. It's known to be efficacious. It has some safety problems. FDA puts out a risk, and the market share or use of that drug goes down because providers and our consumers of our healthcare are concerned about that health risk. Another FDA warning comes out. We emphasize those warnings and teach our providers about those warnings, and our patients are understanding of that warning, and less people end up oftentimes using that drug. In the meantime, new studies from FDA or universities are coming out suggesting that the risk is very small or not a risk. And so now there becomes a disconnect between what the label says as risk, what providers and patients perceive as a risk, and understanding, how do you communicate now this risk that's rapidly changing as we're progressing over a longitudinal time. And I wasn't sure who's really going after that piece. Is really at the doctor's office, when I have a patient in front of me, I have to communicate if they continue, let's say, smoking. Your risk is this. If you use an anti-smoking drug, or if you use no drug, great. But if you can't stop, your risk is this. If you use this drug, it has a small risk, but a meaningful risk, or a small risk, but much less than if you continue smoking. And I think that piece is missing as we're moving down very rapidly because of the Sentinel, of catching up to risk communication in the doctor's office to the patient, who, because docs will go to the label, or they could try to go to NIH or to Medline. Who owns that piece? That is an unbiased consumer of that information.
Yeah, that's a great comment. I think there's a number of folks on the panel that might have some thoughts.
Well, first of all, I agree with you completely, and we sort of all own it, but we certainly haven't gotten that balance right yet. We have, from our patient populations, those very real examples that are even to the point where products have been taken off the market, and persons for whom they work no longer get that product, and therefore often they're back out of the workforce, they're disabled, where for them it would have worked. And so I think that we've done quite a bit of work now on how people think, that have people with chronic conditions, one or more, how they think about that risk benefit, and finding ways that it's easier to communicate that versus others where none of us would get it. And so I think it's an incredibly real problem. We're very aware of it. We're trying to take some actions to better communicate, and we've had a lot of conversation, I know people here that have been here before, about the importance of communicating, not just about risk benefit, but all that like Sentinel is doing, how to do that, what are the intermediaries that are the best vehicles for communicating to people, to patients. And so I would say we've done research to know that these patient advocacy organizations, tied with doctors at times, but are the most credible resources to convey information to patients because they are there and believed to be for them. They have data, they're evidence-based, and they have no other motivation. So one of the things we want to do as we get better at this, and working with FDA and others, is use these organizations who have multiple means of communicating with the populations they represent, and then have them be one of the intermediaries that's the most trusted source of how to think about benefit risk, but get down to the point where we are addressing specific products, because we have had people have really negative outcomes because their product is no longer available, it's either pulled or the prescriber will no longer prescribe it. And it's just, it's not appropriate.
Thank you.
Good. Sharon?
Yeah, I'll just make two quick comments. One is completely agree with Merlin. I think what we've set up inadvertently is an information asymmetry between the doctor and the patient, or between the research system that's brought about the information and the clinician, and reducing that information asymmetry through participation of all these stakeholders will help. The other thing I think is looking at how do we essentially change the culture so that the information flows both ways, and that we're recognizing that this is not a binary kind of decision making that happens, but that it's an ongoing learning healthcare system. I think one of the biggest secrets in America is that we all think we go to the doctor and he or she has the right answer, and the second secret is that we don't know that we're part of the answer, and I think changing those things culturally will make a very big difference.
Great, thanks. We're going to just take two more questions. Go ahead.
Well, I'm going to make a comment. I had the luxury of having had the experience of watching how polio was eradicated from the Americas. And it was obvious that it couldn't be done by independent efforts, needed to be coordinated from the top. but also you needed to receive information from what was happening in the field. We have a problem, I'm hearing, about standardizing the names of unique products. If we are going to do the effort by database, doing it independently, we are, in my opinion, will be very difficult to solve. Needs to be coordinated from the top. But at the same time, it needs to have the field information, what's happening, which are the exceptions, which are the problems that we encounter, because having a better way of identifying unique products is the core of how we can analyze medicines. The same thing for devices, no?
Great, thanks for that comment.
Hi,
Yeah, please go ahead.
Okay. Hi, my name is Xiaofan Zhao from Pfizer. Mini-Sentinel common data model is a key component for our Mini-Sentinel active surveillance system. And Mini-Sentinel pilot project has made a tremendous progress in this area. I'm very glad to see that IMEDS is leveraging this part of the resource. With more data partner or users to use common data model, we know that it is challenging to keep the quality of the common data model, and particularly if you wanted to updating and constructing a new common data model. So I wonder if there is any plan for training the proper use of common data model, or even there is any plan for a guidance of using a common data model, because this type of information will be very useful to ensure the validity of research results. Thank you.
That's great, thank you. Any comments from the panelists? Troy, do you want to?
Yeah, I'll comment. First of all, IMEDS we're really agnostic as it relates to the common data model. We believe that lots of good work has been developing the Mini-Sentinel common data model, as you just pointed out. There are others who would say that the OMOC common data model has certain advantages. So within the IMEDS research laboratory, we are actually supporting both common data models so that we can allow researchers such as yourself and others to be able to get a better understanding as to what are the attributes in the bigger picture, what are the attributes that each common data model may have, such that at some point we will get to that point where we truly do have just one common data model instead of a whole bunch of different common data models.
Great, thanks. Okay, before anybody moves, I'm standing between you and lunch. But at 1:45, the next session will begin. It's got a fantastic lineup of panelists that will finally get to talking about how this great resource that has been developed could potentially be useful for other national resource needs. So until then, I'd like to thank all of the panelists on this panel,